So that's what I'm going to talk about today, surgical management of orthopedic peripheral joints. Obviously, you can see that I omitted the word spine because that will be covered by my colleague later today. Now the good news is that most patients with arthritis will never need surgery because the rheumatologists are so good, we have just heard that they can control the disease with medications. The ones which cannot be controlled, they come to us. And another common factor is that regardless of the type of arthritis, the goals of treatment are similar. It doesn't matter whether it's rheumatoid, osteoarthritis, SLE, or your mixed connective tissue disorder. I think we have the same modalities. And treatment is indicated for patients who, despite adequate treatment by the rheumatologist or general physicians or internal medicine people, if the symptoms persist in the form of pain, deformity, stiffness, and loss of function, then we come into the picture. The aims of treatment are relief of pain, as it is in most situations in medicine, and we tend to retard disease progression, correct deformities, and enhance quality of life. The important thing is that surgery is often recommended before arthritis causes complications such as muscle loss and joint deformity, because once they occur, then the treatment sometimes does not give you the result you're looking for. Now we have lots of options. As you can see, I'll just go through what it means for people who don't know these terminologies. Excision of bone. Sometimes we treat this condition by excising part of the bone. We remove a part of the bone to improve function and relieve pain. Synovectomy means operation on the soft tissues. You have hypertrophy of the synovium in the joint, and sometimes to retard the disease progression, you do synovectomy. Arthrodesis means fusion of the joint. When the joints become painful, when they move, they cause more pain. So what you do is you stop the joints from moving, and this is called arthrodesis. Osteotomy means division of the bone. So when there's deformity, you cut the bone, correct the alignment, and that improves function. Arthroscopy is a new modality over the last 30 years, and this is you put in a camera, look inside the joint, and treat various conditions causing problems. Arthroplasty, well known to everybody, is also called joint replacement. The joint can be replaced entirely or partially. Then there are some new modalities which are applicable in certain joints of the body. Microfracture is used commonly in the knee joint, and this is, in the past it was used for injuries of the cartilage and younger people, but now this use has been expanded to arthritic patients who are young. Chondrocyte transplantation is another modality wherein you can take cartilage from some parts of the joint and bring it to other parts of the joint which are arthritic. Distraction of joints, another rare procedure. It is applied to the ankle joint. If you cannot do any of the things mentioned above, then you can just put pins above the joint and below the joint, and you can distract it, which means making a little bit of extra room for the joint to move. In the lower extremity, I'm going to cover all the 4 joints one by one. And what I've done for convenience, I've put all the modalities on the top, and I've highlighted the one which is used more commonly for the problems. Now here you see in the picture, there is an advanced arthritis of the right hip joint. The left joint is pretty normal. Now if you just to give you an idea, many years ago, we used to do excision. Part of the joint used to be removed, and the joint was left supple, and it was done, but it did not give good function. Osteotomy was also done below here at that point to realign the bone, but again, in modern day, it is not done. Arthrodesis, a long time ago, all younger people, when the arthroplasty did not exist, the joints were fused, but it caused some problems in the knee and the back, and that was also abandoned. Synovectomy can be done for selected cases, but it's more popular in the knee and gives better results in the knee. Arthroscopy is another new thing that can be done for the knee for early synovectomy. However, the best surgery is arthroplasty, which means replacement of the joint as you see in this picture. So this is the joint which is replaced here. And of course, later in the day today, you will hear more about it. This is another example of advanced osteoarthritis of the left hip. I showed you a picture of the total hip. Now this is in a younger patient. If you don't want to do a total hip, the life of which is limited, and if you need to operate on somebody who is in his 30s and 40s, you can go ahead and do this, which is called resurfacing arthroplasty or minimal joint replacement. The life of this for the moment is about 10 years, so if you need to revise it, it's very easy to remove this. The bone stock is still good, and then we can change it to a total hip replacement. Another situation which can lead to arthritis of the hip is the avascular necrosis, very common in Bahrain, and when it causes that, of course, the only alternative you have is a total hip replacement, as you see in this picture. Now you see in the picture below, there was a smaller device, this is a bigger device. We use different size femoral heads for different situations. Now with most forms of arthritis, you know that bilaterality is common, so sometimes you have to replace both hips. It can be done simultaneously or one after the other. In this particular picture you see the two hips of different types because it was done in two different centers by two different people. Coming to the knee, again, if you look at the options, there are so many options available. Probably the best in advanced cases is still a joint replacement. In this particular case, you can see the medial joint is the one which is affected. The lateral joint is not bad. So why not do what is called a partial knee replacement, leave the lateral joint as such. This is the lateral view and that's the AP view. So this suffices in a lot of people. If this were to fail or if you were to get arthritis in the other compartment, then the whole joint can be replaced. This is an X-ray of both knees showing medial compartment osteoarthritis here, not so bad on the other side, but it's moderate to advanced, so you can do a partial replacement on both sides. Another X-ray of an advanced osteoarthritis of the knees. Of course, the medial side is more affected, but as you can see, the lateral compartment is not so good, so it's a good indication for what would be a total joint replacement. Now this is a situation where you have advanced osteoarthritis here, but you see there's at least 20 degrees of bend in the knee. Now if you were to embark on a total knee replacement, sometimes we are not able to correct the deformity completely. In situations like that, as I have highlighted on the top again, you can do two procedures at the same time. This is a picture showing an osteotomy. This is the plate here with a opening wedge osteotomy, which means the joint was opened on the medial side, a graft was put in, the knee was straightened, and after that, the joint was replaced. Now, a condition very common with the rheumatologists, psoriatic arthropathy, and it causes a condition called lipoma arborescens. One of the patients sent by my colleague, Dr. Emil Hanna, and I think Professor Badavi also knows about it. We had an MRI, and Dr. Farah sitting here had reported this, and this is the patella. You cannot imagine the amount of florid synovitis that psoriatic arthropathy patients can have. This is the other side of the joint, the meniscus. There's a lot of synovial hypertrophy here. And one of the things you can do is just shave off the hypertrophic villi and the patient's benefit. This particular patient had aspiration of the knee about 18 or 19 times, and none of the treatment worked. And after synovectomy, he has been doing fine, and he's following up with our rheumatologist in the hospital. So it's like an underwater deep sea diving. People will know what it looks like. Very florid. And we put our shaver inside. And what we do is a very painstaking job. Sometimes for an hour you just keep shaving and shaving until the whole thing is done. I will not go through the whole of it. Another situation where you can do arthroscopy is rheumatoid arthritis. As you know, synovitis is one of the main pathologies you get in this one, and later a pannus forms which can destroy the cartilage. So again, we put in our shaver and we clean the entire joint up. We go down further down to the lower extremity. Ankle is another common area where you can get a lot of arthritis. You don't have much options here. One of the most popular treatment is arthrodesis, which means you fuse the joint. It is done by denuding the articular cartilage and you put in screws, and then the tibia and the talus, they become one piece. The rest of the joints are fine, and the patients do extremely well after this procedure. This is to show you the arthritis in the talonavicular area, different stages of arthritis here. It's so advanced that part of the navicular has come out, and this is all completely shattered. This joint can be fused. I don't have an example of this here, but one of the options could be to fuse it. If the joint is really destroyed, you can take out, that's called excision, take out part of the bone. This is ankle joint is not so bad, but the talonavicular, the talocalcanean, and the calcaneocuboid joint are affected. So this is called metatarsal osteoarthritis. You don't have many options here apart from arthrodesis. So the joint is fused, the ankle is left free. All the other joints are fused. Yes, you can see there's a lot of hardware used, but this is the only way it can be done. This is the close-up of the same. The calcaneocuboid joint is fixed, the talonavicular is fixed, and the talocalcanean is fixed. And the ankle joint is fine, so the movement of the ankle continues, and these patients do extremely well for relief of pain. This is another purely ankle joint osteoarthritis. The rest of the joints are fine. Some people will probably go ahead and do an ankle replacement. Replacement of ankle, of course, is not as good as the hip or the knee, but it is still popular, and I'm sure you'll hear about it again later today. If you quickly go on to the upper extremity, again, you have four major joints. This is osteoarthritis of the acromioclavicular joint, which is very common. The shoulder joint as such is good. The best option we have is to remove part of the bone, as you see in this example. We take out about 1.5 centimeter of the clavicle. The joint still remains stable, and functionally it works very well. Glenohumeral arthritis, which is the main arthritis of the shoulder joint, is very rare. It's not as common as the knee or the shoulder. However, it does occur. When you have a situation like this, the best thing to do is to replace it. Fusion is not a good proposition here. And this is the wall, and this is the results are reasonable. There is also a condition called rotator cuff arthropathy. Just to go back here, you see the joint here. The joint is still in line. They are articulating with each other. If you go into this, the joint is really, the head of the humerus has gone out. This is the patient who had a tear of the rotator cuff. So when there is no rotator cuff, the head of the humerus tends to migrate upwards. Again, it is arthritis, so what we do is replace it. But however, this is called reverse shoulder arthroplasty. If you remember the previous picture, the ball was here and the cup was this side. This is reversed. Apparently, this situation deserves this procedure because the rotator cuff can be attached to the fragment here much better, and the results are better with reverse rather than the conventional arthroplasty. This is a rheumatoid elbow. Again, in the past, fusion was one of the modes of treatment, but in modern day, the elbow is replaced and the functional results are reasonably good. This is an example of a radiohumeral arthritis more than the ulnohumeral. So when you have part of the joint involved, you could do what is called a partial joint replacement. The radial head can be excised and this device can be put in. This is the intro picture. And the results again are fairly good. Come down more distally to the wrist. This is rheumatoid wrist. All the intercarpal joints are affected, including the radiocarpal as well as the radioulnar joint. One of the best options is fusion. The cartilage is all removed and a plate is put across. This is the APN lateral view. And fusion, obviously the patient cannot move their wrist, but the hand is still functional. Another example of a rheumatoid arthritis here. And you have another option of a wrist joint replacement. There are two ways the joint can be replaced. One is a pure radiocarpal by excising the distal end of the ulna. Some people even prefer to put a replacement for the distal Holland. If you get it in your fingers, this is the metacarpophalangeal joint, this is the proximal interphalangeal joint, and somewhere here is the distal interphalangeal joint. All joints can be replaced, and I'm sure Professor Mai will talk about it later in the afternoon. This is the replacement of the MCP, the metacarpophalangeal. This is the PIP, the proximal interphalangeal. And this is the DIP, the distal interphalangeal joint. Again, the rheumatoid hand, where the metacarpophalangeal joints are unaffected. One of the older methods of treatment many years ago we used to do was replace all the joints in one sitting by a silastic joint implant. So there's no metal adjusted plastic or silastic, and it used to give good results, and still being done. At times you have an isolated DIP, distal interphalangeal joint osteoarthritis. The tip of the fingers become deformed and you lose the pinch grip. So one good option is to fuse this joint. It can be fused by excising and just putting simple sutures, but nowadays we have screws called Herbert screws, wherein there is no screw head, the head itself gets buried, so there is nothing you see at the distal end of the bone.
Yeah, I think you're right, because
it wasn't too that.
it depends on the surgeon himself, because if you remove all the synovial membrane, there is no chance of synovial growth. But if you don't remove the membrane, especially I think the posterior part, the posterolateral part, you still have recurrence. I agree with you, because I've seen patients who have done this, because it depends mainly how skillful the surgeon is. Because as you said rightly, if you take all the synovial membrane, so there's no synovial membranes left. The other thing, if you don't control the disease medically, flare-up might occur, and part of it may be the arthroplasty joint, which arthroplasty has taken place, if there are remnants of the synovial membrane.
That's what happened. I had a patient who had bilateral due to rheumatoid. She just had it in her knees. And she went in for many years, okay, and then she started having swelling. It's warm, isolated joint, there is inflammation, and her inflammatory markers were high, and she had a recurrence of that disease.
I think recurrence of a synovectomized joint by arthroscopy is common, but not every place. However, may I invite Professor Mai, do you have a comment?
It can happen that you replace the joint and you, after some time or after a short time, you can have still a rheumatoid activity in the joint. They don't recommend nuclear therapy. This means radio synovectomy or chemical synovectomy. This acts very well. I'm also very afraid if you do a corticosteroid injection, it can cause an infection.
Thank you.
As another point is, sometimes you have an allergy of the matter. So in persistent swelling of the replacement, check the allergy reaction of the skin, especially chrome-colored and molybdenum.
Okay, final comment from Dr. Saini.
I share the experience of what you said before of recurrence, but probably what Dr. Malhotra has said, if the arthroscopy is done, the cleaning of the synovium is really up to down to the point is very well done, we will not have recurrence. The problem that we foresee every day is not in rheumatoid, it's in psoriatic arthritis. Because in psoriatic arthritis, it's very frequent. I don't know how is your experience, but we are dealing with another disease.
That's correct.
The synovectomy is not enough, because we are dealing, unfortunately, with whatever is around the joint, and this is driving us crazy. So the problem is what we are going to do with a psoriatic patient that had a joint replaced. Sorry.
Right. Thank you very much. Before I conclude, I'd like to thank the three eminent speakers, Professor Soili, Dr. Hamid, and Dr. Malhotra. We'll have a coffee break now, and we'll convene here after half an hour. Thank you very much.